So I think when at the outset, I do acknowledge we receive research grant support from Alcon Laboratories, and I acknowledge the contribution of our colleagues at Raghudev Eye Hospital in making this presentation. So whenever, right now we are doing all of this virtually, but whenever we visit any conference and go to the trade area, there are zillions and zillions of newer equipments that have come up, and each equipment is supposed to be the best in the world and something that you cannot do without in your practice, and is going to be the next big thing. So are all of these so many fancy equipments really needed? Is it a necessity? Is it a fad? What is it? So let's go through one or two of cases to identify which investigations are more useful than others. So this was a kindergarten teacher, 45 years of age. She's been a myope since a very young age and contact lens user, and now finds it difficulty in tolerating contact lenses, and came to us for an opinion of clear lens extraction because she's never worn glasses all her life, and she likes to be seen without glasses. And now, because she's not able to tolerate contact lenses, she's having to wear glasses. Now, when we evaluated her, we found that there was the tear film evaluation showed an extremely high breakup time. I mean, very fast breakup time. And the eye trace showed bizarre corneal aberrations. So we decided that we are not going to even talk about any form of surgery as of now. This is the corneal aberration profile of the patient without any treatment. And we told her that we need to treat your ocular surface first before even discussing possibility of any form of surgery to reduce dependence on your glasses. So after 3 months, the patient improved her aberration profile. She has negligible astigmatism, and she became a candidate for refractive lens exchange. So this is the same patient pre-treatment with a poor ocular surface. And look how almost all of the ocular surface aberrations have gone just by treating the ocular surface appropriately. So I think dry eye assessment is often underlooked or is laughed upon at, but is one of the most important factors in deciding the post-operative happiness of the patient, because not only are the symptoms going to bother, but like Dr. Samresh very correctly showed, your measurements are also going to be inaccurate with a bad tear film. There are several tear film measuring devices and tear film osmolarity marking and so many different instruments. We have limited experience with this tear film analyzer IDRA, which is I think sold by My Healthscape in India, and it gives us lot of information regarding the tear film. So this report is showing us just the tear film meniscus height. It comes with normative values also, but also you can look at the raw images and look at the actual tear film height. You can look at the tear film breakup time, and if you find that the tear film is breaking up very quickly, it will show up on these spots. If these spots are too many red spots, that means this is breaking up too quickly. And you can also get mebography to actually identify the cause of this poor ocular surface, because each requires a different form of treatment. So these investigative devices are definitely helpful. They are not a necessity in day-to-day practice, but at least it definitely helps in patient education. So if the patient has certain symptoms, we can show it to them that, look, this is the cause, and therefore we are suggesting X, Y, or Z treatment, or therefore we are not suggesting a multifocal IOL for you. There are tear film analysis devices like MMP9 markers, which give, if they are positive, suggest an inflammatory cause for the tear film. But like I said, the role in a day-to-day clinical practice is probably limited, and I wouldn't say they are the number one investigations which you should invest on for premium practice. I think this is one investigation which all of us should be looking as a basic now in our practice. That is the optical biometer. And optical biometry has evolved tremendously over the last decade and a half. And the newer optical biometers, what they call as the swept source based biometers, is nothing but Fourier domain OCT based biometers. And the reason why they are going to be the future is because they have a very high penetration rate even in the densest of cataracts, which is more relevant to our part of the population than, say, in the Western population. And we did our own study where we compared Lenstar versus the Tomy swept source OCT, which we have access to both of them. And we found that while in the Lenstar, we were able to achieve axial length in 84 percentiles. We were able to achieve axial length readings in almost 98% of eyes with the swept source OCT, which means except for those extreme wide cataracts, it penetrates through almost everything. And that improves your IOL prediction, your calculation, your post-operative outcomes. And this is what we published last year. The same data showing that about 1/5 of patients, almost 20%, could not be captured on the Lenstar. This is another case. A patient came to us for a second opinion, complaining of glare. Very well done cataract surgery elsewhere, full diffractive multifocal IOL, retina is normal, OCT is normal, everyone has seen him and everything is perfect. But when we did his eye trace, we found that there are a lot of unexplained aberrations internally, and there was no PCO. It's a crystal clear posterior capsule. So if there is significant astigmatism, we can understand, but all of these were not adding up as to why this patient is having so many ocular or dysphotopic phenomenon when everything else seems to be good. When we looked at it, we found that his angle alpha was quite high, which means that the centration of the IOL was such that the rays of light were actually passing through the rings of the IOL. So in spite of a perfect, refractive outcome, the patient had a poor quality of vision because his angle alpha was quite high. So what is the role of angle alpha for a cataract surgeon, and how can we evaluate it? And I think I acknowledge the contribution of Samresh present in making and explaining these slides to us, that the IOL basically sits in the center of the capsular bag. Now, there's no way we can measure the center of the capsular bag. So therefore, we sort of use a surrogate measure as the center of the limbus, whereas the light is actually going to pass through the visual axis. So when the difference between both of them is very high, the light rays are going to pass through the rings of the multifocal IOL rather than the central zone, which is the clear zone. And therefore, these patients have photic phenomenon more compared to others, in spite of everything else being normal, perfect biometry and everything else. So any angle alpha more than 0.5, you should keep a close eye on that. The only positive part with the newer trifocal generation of IOLs is, particularly with the PanOptics, and I'm sure the others coming up will do the same, is that it has a larger central bullseye, which means it is more forgiving for angle alpha. With the traditional multifocals, we were more fastidious and we had a cutoff of 0.4 actually before the trifocals came in. Now we are a little more liberal and go up to 0.5 or 0.6, but anything beyond that, be cautious that this is the patient who's going to complain of the photic phenomenon. I think, as has been highlighted very beautifully by Dr. Ramamurthy, that OCT evaluation is now becoming more and more mandatory. So this is a fundus photo image of a grade 2 cataract, which we're planning for cataract surgery. Absolutely nothing in the fundus, healthy disc, now normal looking fovea. And when we did the OCT, we found that there was an epiretinal membrane. So this was missed not just by the cataract surgeon, but also by a trained retinal surgeon who had seen this patient multiple times before, including in the preoperative time. So I think macular pathology is something that is the biggest bugbear for post-operative poor quality of vision, irrespective of monofocal or multifocal IOL. And we did our study evaluating all the pre-operative patients we do as a routine in our practice. We make them undergo posterior segment OCT. And the patients were clinically evaluated by retinal surgeons, and even the OCT was evaluated by the retinal surgeons. So the first important observation that we found in our study was that a reliable OCT scan could be achieved in 95% of eyes. So even in very dense cataracts, in most cases, you are able to get a good signal strength enough to get a reasonable scan. And macular pathology was identified in 18% of eyes, where it was labeled as normal retina, normal fundus, normal fovea by the retinal surgeon himself. And the most common pathologies that were found were ERM, RP irregularities, and then foveal atrophy, vitreomacular traction, so on and so forth. Another clinical example of a seemingly apparently normal looking fundus but had vitreomacular traction or a lamellar macular hole on OCT examination. And this is something, this is why the article that we published regarding the role of OCT and subtle pathologies detected on OCT when screened clinically by all cataract and retinal surgeons. So I think these are some of the newer investigations which I think sooner or later are going to become a part and parcel of our cataract workup. And I think if I have to highlight two, optical biometry, particularly the newer generation swept source based OCT based biometers, and posterior segment OCT are, I think, going to become a norm as far as routine preoperative cataract workup goes. And they help us not only to raise the bar, but improve the predictability and precision with which we operate, and therefore less pre-operative chair time counseling them about unpredictable visual outcomes post-operatively. So thank you so much once again for the patient listening.